Hello, all. My name is Natalia Berry, and I'm one of the structural and interventional cardiologists at the Mid-Atlantic Kaiser Group. And I have the distinct pleasure of hosting Dr. Renee Bullock-Palmer on today's ECR podcast. I'll give a brief introduction. Dr. Bullock-Palmer is the Director of Non-Invasive Cardiac Imaging and the Director of the Women's Heart Center at the Deborah Heart and Lung Center in Browns Mills, New Jersey. And she has a distinguished resume. Alongside her leadership titles, serves on multiple national academic committees, among them the AHA, the ASC, mentors fellows, and has published many peer-reviewed articles. So really an expert in the field. So thank you for being here today, and welcome, Dr. Bullock-Palmer.
And thank you for having me today, Dr. Berry.
Great. So we'll just launch in. Our topic today is an extremely important and timely one. The topic is socioeconomic factors and impact on utilization and resource access in coronary and structural intervention. Briefly, by way of introduction, coronary and structural interventions have undergone remarkable growth in the last decades, as we're all aware. In particular, complex percutaneous coronary intervention, PCI, and as of late, structural intervention with really minimally invasive valvular therapies have both expanded dramatically. And yet, there has been notable inequitable patient access to these therapies, and in particular, the disparities appear to be most pronounced among patients with low socioeconomic status, or SES. We may be abbreviating that today. So, really important topic. I thought we would start with PCI, or percutaneous coronary interventions, because that's really the procedure that's the cornerstone of interventional cardiology. Dr. Bullock-Palmer, what sort of data exist about socioeconomic disparities in PCI?
Great question. So a recent systematic review of over 180 studies had derived from mainly high-income countries show that there was an association with lower SES and the receipt of reperfusion therapy. Although the study findings were inconsistent, the study did not separate the means by which these patients were reperfused, from thrombolysis versus PCI. Another analysis of over 6 million admissions with acute myocardial infarction over a 10-year period between 2004 and 2014 reported that patients in the lowest quartile of median household income were significantly less likely to receive coronary angiography or even PCI, with the greatest effects seen in patients presenting with a STEMI. And residents in low-income areas were less likely to receive even a catheterization within 24 hours of a STEMI. And we know that, time is muscle. So, this is very important. And even for non-STEMI patients, within 48 hours, most of these patients were not meeting that criteria. So there's a lot of work to be done here in this group.
Absolutely, yeah. One of the things that comes up is often how patients sort of perceive their own health and kind of understand what's happening to them, because it's overwhelming for even a very literate or educated person. So I was curious whether you could comment on, how much does health literacy or a patient's understanding of their condition contribute to the effect of this SES effect on PCI? I would imagine that, cultural and social factors really do influence a patient's level of understanding significantly.
Absolutely, especially when we're, facing an increasingly diverse multicultural, panel of patients. It's very important that, decreased health literacy in these patients with lower socioeconomic status may impair their understanding and coping with their underlying heart condition. Because, of course, if they cannot understand what the disease entails, what needs to be done, then how can we expect them to be acceptable for the therapy that we're delivering to them? So I think health literacy has a very important factor to play. This is further worsened by the lack of trust in the healthcare system, particularly among patients lower socioeconomic status, underrepresented groups as well, especially when there's a language barrier. There's a poor physician-patient communication, and that can just break down, a lot of into a lot of issues in terms of patients accepting the treatment that we're recommending. And as I mentioned, this is heightened in patients, coming from a different culture, different language. So it's very important that, if we have these patients that, they understand what we're saying, and we sometimes have to use, translation devices. There are apps. Even a lot of hospitals actually will have a translator available. It's very important that we use these resources. The authors from the previously described study that I mentioned earlier has speculated that the differences that they saw with reperfusion may be due to the perception that individuals with lower income would be less likely to afford post-PCI agents, which of course is very critical in keeping the stents open. There's a strong correlation between education and health literacy. Individuals with poor health literacy are more likely to be non-compliant with their medications. So it's multiple factors, and I think one, health literacy is important. Two, effecting a good physician-patient communication, and really trying to bridge that barrier, when we see these patients.
Absolutely. Yeah, no, it really seems that all makes sense and certainly suggests that the barriers really to overcoming these differences in health literacy are significant. And the eventual approach to kind of reconciling or bridging the gap, if you will need to be multifaceted. So once patients with low SES do eventually undergo PCI, do we know anything or what are the data on any differences in outcomes after the fact?
Right. So it has been shown that patients with low SES scores presenting with acute myocardial infarction, even when they do receive invasive treatments, are more likely to experience a longer reperfusion time, less likely to receive a drug-eluting stent as compared to a bare metal stent when they do go for for revascularization, and are also less likely to receive gadolinium-directed medical therapy at follow-up, because it's not just as putting the stent in, but all of the care that goes with that, making sure that they're taking their antiplatelets and being appropriately followed. In an analysis of over 4 million admissions for non-STEMI patients in the US, patients in the lower median household income quartile were more likely to be managed medically and less likely to receive coronary angiography and angioplasty. The disparities in the receipt of revascularization are not limited to just acute myocardial infarction. Another analysis of over 3,000 patients out of hospital cardiac arrest, patients admitted alive and captured, actually resuscitated. There's even disparity in that as well in terms of how many of these patients are resuscitated and actually successfully resuscitated and brought to the emergency room and subsequently receive coronary angiography. Another analysis of over 100,000 patients in New York State in their PCI reporting system reported that patients in the highest areas of deprivation index quantile, which is a marker for socioeconomic status, were more likely to be young, female, or also Blacks living in rural parts of the country, and with the highest prevalence of risk factors such as diabetes, congestive heart failure, chronic lung disease, tobacco smoking, obesity, and diabetes. Patients in the highest areas of deprivation index had the highest odds of having a 30-day mortality, with the greatest odds of having readmissions within the first 30 days. And this is even after adjustment of multiple differences in the baseline covariates and race as well. So there's a lot of information in this area. And, I would recommend that our readers could refer to or review the article, but there's so much information with this.
Yeah, no, thank you for all that data. Clearly, there's still a lot of improvement needed in terms of improving not only access to PCI and patient understanding around that process, but also the subsequent outcomes, which obviously remain disparate. It also, as I was thinking about this topic and preparing for it to a certain degree, it really makes me think that, as everyone knows here, the sort of randomized clinical trial is the epitome of, sort of robust research. And I do think therein lie a lot of disparities as well, where we know that, for recruitment for these trials, minorities, females, and patients of lower socioeconomic status are really consistently underrepresented, with often minority rates less than 5% for a whole trial. So it's also really an area for improvement going forward as we study large populations of patients and try new devices and drugs and all and so on, because I think that we really need to understand them across all of society, not just people that we can easily recruit for trials. So it's a big problem. So perhaps we could move on to structural heart procedures and take a turn away from PCI, including aortic and mitral procedures. Maybe we could start with transcatheter aortic valve replacement because that's clearly the most common structural heart procedure. Dr. Bullock-Palmer, could you tell us a little more about what we know about any disparities in TAVR?
Right. So, there have been several studies that have shown that there's a positive correlation between income and the probability of having TAVR done. So the lower your income, the less likely, and so on. So a national cross-sectional analysis of Medicare claims had demonstrated that for each $1,000 decrease in median household income, the number of TAVR procedures performed per 100,000 Medicare beneficiaries was 0.2% lower. Even more, for each 1 unit increase in the distress community index, which is a marker again of socioeconomic status, the number of TAVR procedures performed per 100,000 of these beneficiaries was 0.4% lower. So interestingly, the rates of TAVR in this study were lower in the postal code areas with a higher proportion of African Americans, Hispanic patients, despite adjusting for the differences in socioeconomic status. So there's some racial component to this as well. There's also greater burden of clinical comorbidities, and also these patients were older. Other studies have reported that for every 10,000 increase in income, the odds of receiving a TAVR increased by 10%, while non-Black patients were twice as likely to receive TAVR than Black patients. So, there's a lot of disparity there. There's some thought that there's some genetic differences between African Americans and Hispanic patients, which may account for lower rates of aortic valve stenosis on echocardiography. There are 2 studies that had suggested that. So, there's a huge disparity, and I think that's an area that, we need to work on.
Yeah, no, I think the genetic difference question is very interesting. We just looked at our own echo pool of about 20,000 outpatient echoes, and it does seem to be a lower rate as well in our Kaiser population, and we have almost 20-30% African Americans, so it's a pretty robust population. Remarkable. More work to be done here. So we know that unlike PCI, which can be done at sort of a community hospital, and as long as there's cardiac surgery on board, structural heart interventions are kind of restricted to more of a heart team setting, which is typically in a tertiary care center. Do we think that this aspect of the procedure plays a role at all in access?
Absolutely, because as I had mentioned, the disparities, not only reflect the systemic racism and differences in referral patterns, but also the inequitable introduction of these new technologies to, hospital systems that are in the rural areas, in the underserved areas, and I think that's something that is also contributing to the disparity. A study that was led by Dr. Nathan and his colleagues had looked at the characteristics of approximately 500 hospitals that had developed TAVR programs in the U.S. between 2012 and 2018, and they had used Medicare data and along with the patient's socioeconomic position that these hospitals served, and in order to study whether there was a disparity in the diffusion of these new technologies by socioeconomic status. And the hospitals that started TAVR programs during the initial growth of the technology in the US had higher median household incomes and were less likely to be based in areas of lower distressed community index scores. And during this initial growth of TAVR programs, hospitals serving wealthier patients were more likely to start programs, leading to the disparities in the dispersion and access to TAVR in these lower, socioeconomic communities. So I think that definitely it has a part to play. In the U.S., communities with a high proportion of underinsured patients lack the presence of high-quality, well-funded hospitals or institutions within their own communities that have this expertise in performing these interventions. And without the hub-and-spoke model that could reliably care for patients regardless of their insurance status, significant access barriers will remain in place, unfortunately. Government policies, I think, in the U.S., have incentivized physicians as well to practice, to be less likely to practice in these rural and underserved communities, because oftentimes, physicians coming out of training have large, medical school loan repayments and visa wait. There's lots of factors to play. And, oftentimes, for us to recruit physicians into these underserved areas, I think this is an opportunity to have visa waivers for for physicians who, who are immigrants, and also having a loan repayment forgiveness program to encourage these physicians to practice in these underserved areas and develop these very important programs such as TAVR and other structural interventions. And despite this strategy, it is still imperative that we have all, stakeholders at the table to really secure the retention of these highly qualified physicians in these communities.
Absolutely. No, that's great. And I'd love to come back to this a little bit as we, hoping to end on a positive note, thought we would sort of cover the proposed solutions, going forward for some of these disparities. So, but that's a great sort of launch point for subsequent discussion. So it really does seem like geography and accessibility of tertiary care centers in particular is a significant factor for determining access to care, and certainly should be an area of focus, as Dr. Bullock-Palmer has outlined going forward. So perhaps we could just touch briefly on mitral valve intervention, since we just discussed some of the data for TAVR disparity and what we know about disparities in this realm, before we then move on to propose solutions for these barriers.
Okay. So, the studies in this area is a little bit more sparse compared to TAVR. But, socioeconomic status, again, influences the choice of technique and clinical outcomes with mitral valve surgery. In a report from the Society of Thoracic Surgeons, patients of lower socioeconomic position had more urgent non-degenerative mitral valve pathology, and despite this, they received less surgical mitral valve repair and had worse outcomes. Whereas patients with higher socioeconomic positions were more likely to travel, further for their surgery and receive operations from higher volume surgeons. And the data that was regarding mitral valve repair compared to open mitral valve replacement was queried from the NIS national inpatient sample for 2017, and patients undergoing TMVR were older, more affluent, 46, about half of them were female, and there was no difference in adjusted mortality between surgical MVR and transcatheter mitral valve replacement. With regards to edge-to-edge repair, access should be placed in a context that includes the burden of severe mitral valve insufficiency, both primary and secondary. And to date, only one single center study from England actually has assessed more racial differences in the prevalence of moderate to severe MR, with Caucasians having 6.7% versus Black patients 5.3%. And in the US, Black patients have had a disproportionate burden of hypertension, chronic kidney disease, adverse socioeconomic environment, and also structural racism that puts them at a higher risk for incident heart failure with subsequent hospitalizations and death. So it's reasonable to extrapolate that the burden of severe MR may be higher among African American patients, but the data supporting this is lacking. So I think this is an opportunity for researchers in the field to really look at this patient population to study this some more. With studies evaluating disparities in edge-to-edge repair access and outcomes, they've used primarily the NIS data from 2013 to 2018, and the majority of these cases analyzed in these studies were most likely to treat primary MR, since the Centers of Medicare and Medicaid Services recently had approved coverage for patients with secondary MR as of January of last year. And African American patients were significantly younger, had a higher burden of comorbidities, and up to half of them lived in the lowest median household income neighborhood quartiles. So even after adjustment for pre-procedural differences, these patients experienced higher rates of death, but similar rates of overall inpatient complications. And similarly, those living in the lowest income quartiles had worse in-hospital outcomes when compared with those of the higher income quartiles. So additionally, urgent edge-to-edge repair was more frequently seen amongst younger patients, so the Hispanic patients, Medicaid insurance patients, and of course we know that an urgent edge-to-edge repair is not optimal. You want to really have these done electively because the outcomes are better when it's electively performed. So there's a lot of data in this space. I think a lot of room for more research. We definitely have a lot less research in this area compared to TAVR.
Absolutely, yeah. And it just goes to show, clearly disparities are pervasive really through all tranches of interventional procedures, even though we are lacking data, as you suggest. Well, you've really provided us with such a tremendous overview of the current problem. I wonder if we could switch gears just a little bit to discuss potential means of improving these issues, because I know you have some thoughts there. Given your extensive knowledge of the disparity in care we've been discussing for really our most vulnerable patient population, could you talk us through some of the solutions moving forward to potentially address these disparities?
Right, so I think it really has to be a multifaceted approach, starting from, national government, local government with interventions, and really investing more in these communities to provide, institutions hospital institutions, heart centers with that delivers high quality healthcare and improving access to these institutions. Access is something that's very important because, for someone that may not have a car, to take two buses and a train across town, it might seem to be a daunting process for these patients. So we really have to not only build these quality programs within the communities, but improve access, improve public transportation, safe public transportation for these patients as well. A healthy environment is important because, of course, a healthy lifestyle would then, more likely, take these patients away from having these risk factor burdens that they have early in their years, that then leads them to have these valve disease and coronary artery disease. And a healthy environment starts from childhood into young adulthood, middle age, and so on. Really having access to good, high quality, food, safe place to exercise. Education is important. Building good schools where children can, learn and become, adults that can be really engaged in the society, and moving these patients out of the lower socioeconomic status is very important. Now, bringing it back to our profession, I think increasing the presence of medical schools and tertiary care in communities in these lower socioeconomic communities is very important. In New York, where I trained, there's so many hospitals in, all areas of New York City. But as you go further, more rural areas, that's not likely the case. Sometimes patients have to travel 50 miles to get to a tertiary care center, sometimes even 100 miles. So I think, these are some of the areas that could be worked on. And I think, as I had mentioned, this is a multifaceted approach.
Yeah, no, I think, most importantly, you've really outlined that things have to happen at all different tiers. So at the local, national government, at sort of the education, medical school level, and really in the community as well, where we support people at a grassroots level and really try to change their way of just thinking, their day to day, like what kind of snack they reach for, what kind of, like, there's so many things just to kind of, that we can address at so many different levels. And I think it harkens back to what you were talking about as well. I think the role of the physician and having to be that resource for the patient and learning to overcome the language, the trust barriers, using all of the resources we have available to us, including the interpreter systems and family outreach, all sorts of things, but really training physicians better in communication. And I think you really outlined that. Any sort of, I think in taking a step back, we really have our work cut out for us for this disparity issue. And I would highlight that even though this problem of disparity in care for patients of lower socioeconomic status, which as Dr. Bullock-Palmer has really mentioned, seems to affect, certain races in particular, really seems like a difficult one to address. I think it's also critical that we invest resources in this in the ways that Dr. Bullock-Palmer has outlined. Without a doubt, these patients are our most vulnerable patients, and we really have to do a better job providing them access to care, to longitudinal care, and then care that they can really buy into and believe in and understand. Dr. Bullock-Palmer, I just wanted to ask if you had any final comments before I say a few concluding words.
Right. Thanks, and I think I'd like to thank you for the opportunity to, be able to publish this important piece in your journal. And as we're saying, this is not just doom and gloom, but this is one raising awareness of this disparity, and then what can we do as a profession, as a community, as a legislative government to improve, and to dispel these disparities. So thanks for shining a light on the situation, and hopefully with the proposed solutions that we had in our article, it will lead to greater thoughts and probably putting words into action.
Yes, please let us know if you're running for any kind of medical legislative leadership, because we'll all vote for you based on all your solutions. So thank you. This concludes our program today. On behalf of the European Cardiology Review, I hope that you've enjoyed our discussion about this critically important topic. Biggest thanks, of course, to Dr. Bullock-Palmer. Pleasure to see you, meet you. Thank you again for being our guest discussant today. It's really just tremendous to hear from you, especially with all of your expertise and knowledge on this topic. So thank you for being here.
And thank you for the opportunity.